Okay, I think we're going to go ahead and get started in the interest of time. We are missing one of our panel members, and we don't give her much of a break anyway, so hopefully she'll wander in, and I'm sure she'll be able to fit right in with no trouble. She doesn't break stride too often. This is Dr. Kozlovskaya. Thank you for this opportunity. We're going to cone down the topics now tremendously from station programs, mirror shuttle programs, Skylab, Salyut, and now we're focusing on a topic, a physiologic topic. But I would say that it's probably the most significant physiologic discovery in the spaceflight arena for 10, 20 years or so. It's teaching us something we didn't know about basic physiology, and it was right under our noses for a lot of time. And what I would say around this is that the ISS is doing exactly what it was designed to do. By giving us tools in orbit, by giving us accumulated flight experience, we're able to find things that we didn't discover before. We didn't know they were there. And it also helps us to characterize them in a way that's really unprecedented in the past. We came aware of this problem. This is the vision and intracranial pressure issue, and we were fairly quickly able to bring tools to bear, imagery, both in flight and on the ground right afterwards, and really get an idea of what's going on in a much quicker fashion than we've ever really been able to do in the spaceflight world before. So I don't want that to be lost on us. It's a big issue for us. It's a potential problem, but it's also quite a great discovery. So with that, we've assembled a panel to try to give you a snapshot of what this problem is like, or what this issue is like. And I myself am not an expert on this issue, but I guess I can say I'm a consumer or a participant, because while I was in flight, actually myself and another physician crew member, Dr. Thursk, and we've been very candid about our findings, noticed some vision changes, and some very industrious folks on the ground were able to fast track some hardware into space, and we were able to do fundoscopic images, very high resolution images, ultrasound, tonometry and various other measurements, and get that to the ground and really get a good characterization on this. So as a consumer, I defer to the experts who can tell us what's really happening. Now I'm going to introduce the panel members, and we're going to try to be snappy as we go along here to make up a little bit of time. I was going to do it by seniority, and she's not here, so she's not here to defend herself, but Dr. Kozlovskaya, Inessa Benedictovna, a longtime friend of mine, academician. I think long ago she actually invented the nervous system, at least she told me that. You will not find a greater specialist in neurosensory aspects of adaptation to spaceflight on the planet. She's amazing. Dr. Bogomolov, Valery Vasilyevich, again, a longtime friend, Deputy Director of the Institute of Biomedical Problems. I think well known to be one of the elder statesmen in the international medical community. He's a very steady hand at the wheel in international collaborations. Dr. Katuntsev, Vladimir, a specialist also from IBMP. Probably nobody knows more about the medical aspects of EVA than Dr. Katuntsev. He's been a long-time consultant to us as well. Dr. Volker Dahmen from ESA, a longtime collaborator, experienced as a flight surgeon both in the short and the long duration world, founding member of our multilateral medical operations panel. Very active in the international community, and I believe head of the crew operations office for ESA. Is that correct? Okay. Dr. Stephen Hart, a longtime flight surgeon, also a neurologist, aerospace medicine specialist, experienced both with long and short duration flight, was our lead flight surgeon for the International Space Station program for quite a while. Inessa joined us as you...
I'm sorry.
That's okay. We started anyway. And one of our resident experts on the clinical practice, how we apply these findings to actual space medicine aspects of this problem with intracranial pressure. Dr. Christian Otto, emergency physician, experience in Antarctica, 2 years, I think, 2 separate tours of duty over a period of a year as a scientific and medical officer there. He's a climber, world adventurer. He's actually we pay him to be the manager of this risk, to really know everything there is about this. We don't pay him to be passionate, but he really is. And keeping him to 5 minutes will be a challenge, but we're going to try. And Dr. Larry Kramer, who's a radiologist here at the University of Texas Health Science Center, an expert on the anatomical findings associated with this issue. And that's where we really get to look at the nuances of the changes and stratify what happens with long duration versus short duration flight. So with that, I'm going to turn it over to Volker Dahmen, who's going to give some general comments about recognition of this syndrome.
Thank you, Mike.
I've been pushing papers for too long of a time, so I'm not the expert on that eye issue, so I leave it up to the experts later on. But I would like to give you an introduction in where we are, what we have seen, and maybe what are the burning issues also in the international dimension. As Mike said, we as a medical community, we were somehow surprised to find those findings. And have we overlooked something in the last 50 years? Is it something specific to long duration spaceflight? Is it something specific to the vehicle? So those questions came about. And if we have something overlooked, why have we overlooked it? Is there something in our process that we have to review? So those were initial questions when we started to get this mosaic together, this puzzle together. So what we have seen are hyperopic shifts in the astronauts. Of course, astronauts may report post-flight, well, I have some visual changes. To what extent are you taking it serious in terms of, are you documenting it or are you following it up? So that may have been the case in the past, that certain things entered the medical files but were not followed up to an extent that we should have done it. But that is something that, of course, now needs to be investigated. We see elements, issues that are worrisome. We see, besides those shifts, visual acuity shifts, we see globe flattening of the eyeball, we see choroidal folds, cotton wool spots, optic disc edema, elevated intracranial pressure. All those items are worrisome. Usually you see those in patients who are significantly ill or injured and maybe going to the emergency room immediately. But of course, we see those symptoms, but we don't see a disease, a pathology, an accident, injury at the same time. So how does what we see match to microgravity? What is even more challenging is that we don't see those effects in all of the astronauts. Is there a difference? Is there a gender difference? Is it really only on long duration space flights, or have we not looked thoroughly enough into short duration flyers? Why in some individuals only one eye is affected, or why is there a difference between left and right eye? Are there any environmental factors that may drive what we are seeing? Is it the usually elevated CO2 levels, which is known, elevated CO2 to increase the intracranial pressure? Is that something which is specific to the ISS? Is that one element? Is it sodium diet? Is it vitamins? Is it at that time when we discovered it, the new resistive exercise that came on board? So I'm just listing a few elements, and I think that was also the very healthy discussion we had in the beginning. So just put everything in the jar and let's discuss what could be the potential smoking gun, so to speak, to find out what the underlying factors are. Also, are there genetic differences? So are there cultural differences? So we had initial discussions with our Russian colleagues. Have you seen it? You have experience in long duration space flight. So could you tell us what you have seen? Have you understood the issue? And I think also today's panel will be very interesting from that aspect. And of course, if we have such findings, then the questions come up, how do those findings resolve over time post-flight? Do they resolve? What is the time course? Is it medically and ethically okay to refly such an astronaut again if we see that there are changes that may impact the health status of an astronaut? And then, of course, I don't know if the president of RICE, Mr. Lebron, is still here, but then you may have to bring some lawyers into the system because you may have to talk about workers' compensation. Is it something from a legal aspect? Is it an occupational hazard? And if we from a medical community know that there are changes, and maybe some astronauts may claim certain workers' compensation in the future. So, those are ongoing discussions, I think, in all agencies involved. So, to conclude, I think what we need, of course, is a way to treat and prevent this. But of course, before we can treat and prevent, we should understand what is it really we are talking about. And of course, that requires that we implement standardized processes and profound clinical support that we can really document what we are talking about. We need to find a way to measure the intracranial pressure non-invasively. Of course, nobody really likes to get poked with a needle and then other technical possibilities that we can do. So that may drive technological developments among the partnership to find nice means to measure the intracranial pressure. Ultrasound on board, so we need to find standardized ways how we can do that, and Christian certainly will talk more about it. And of course we need to standardize pre- and post-flight data taking with all the astronauts to really compare what is post-flight and pre-flight. And I think Larry will allude a little bit more to that, what we are currently doing post and pre-flight. We need to study the long-term consequences, of course, with the astronauts. Now that we know that we have an issue, so the lifetime surveillance study of astronaut health, I think, is a good tool that we can employ. And of course, we have to raise the issue and have to increase the relevance of that issue also vis-a-vis the program management. We need more crew time if we want to do more on-orbit evaluation of what we are seeing there, more ultrasound time. Imaging, for example, and other examinations, we need more crew time. And as you have heard before, there is, of course, always a fight and battle between the science, the medical operations, technology, the operations, how much crew time every partner gets. So at least we have to escalate it to a level of importance that also the program office understands that we have to look into that issue. And as a last point, we really have to initiate, and already started in a very nice way, collaborative efforts among the research community on one side and the medical operations community on the other side, something that has not been done in the past to a big extent. I think with this issue we can all resolve it as, say, clinical physicians, medical operations, the flight surgeons, the flight clinic, plus the research community to resolve the issue and to consistently collect and analyze the data. And for that we need the appropriate data sharing requirements, which are in the working currently in the MMOP and other panels, but that is something how we can confidentially share the data from an intellectual property right on the science side, but also from a personal medical confidentiality on the astronaut side. So in summary, I think this medical issue and the understanding and solving this issue really requires collaboration across many different involved entities. And at the end, I think that is what ISS is really all about, collaboration and getting the issues and solving the issues. Thank you.
Okay. Thank you, Dr. Dahman. And in the interest of time, I'd like to hold questions and move down to panel, and we'll open up the floor to questions at the end. And Dr. Otto will talk about a little bit more of the detail of the clinical findings and our mechanistic understanding.
Great.
In 5 minutes.
So it's really fascinating to be involved in this problem. It's rewarding to a physician's career to work on a clinical entity that is newly discovered, et cetera. And so Mike has asked me to review the evidence and findings with some of the associations. So just briefly in the next 5 minutes. And I'll be referring primarily to the U.S. astronaut population because that's what we've looked at thus far. The active astronaut population, the mean age is 47. Most are presbyopic. 80% wear corrective vision. And in a post-flight questionnaire done looking at astronauts between 89 and 2011, 25% a short duration and 50% a long duration reported a subjective change in their vision. I'm sure many of you are aware of the space anticipation glasses, so those were actually developed for spaceflight because of this change in vision. So the common characteristics of the cases, and there's 15 U.S. cases spread across varying severity, and I'll just briefly touch on that because Dr. Hart is going to give you more details on it. The common characteristic of the cases, they've occurred during a 6-month duration on ISS, and there's a caveat there, and if we have time, I'll just mention a few words about shuttle. There does appear to be a dose response in the data. All had normal pre-flight eye examinations, and their past medical history was negative for systemic disease. None had used any medications before or during their mission that may have increased intracranial pressure, such as vitamin A, corticosteroids, etc. I'll say this statement with a bit of a caveat. None had complained of headaches, transient visual obscurations, diplopia, pulsatile tinnitus, or vision changes during eye movements. And these are symptoms associated with idiopathic intracranial hypertension, but I think many of you are aware that it's a common complaint among crew members when they first reach orbit of having headaches, stuffiness, etc. That was often felt to be a space adaptation syndrome, but is an element of that related to elevated intracranial pressure? That's an interesting question. None have experienced losses in their best corrected visual acuity, color vision, or stereopsis. The ISS cabin pressure and oxygen were at normal levels. However, as has been mentioned, the CO2 has been elevated. In fact, mission averages were 3.56 millimeters of mercury, which are 10 times sea level. And you have to remember that CO2 is the most potent vasodilator. For every 1 millimeter increase in PaCO2, you'll get a 4% vasodilation. And with that cephalad fluid shift, that is probably one of the primary mechanisms to the elevated ICP. On top of that, you'll get a further exacerbation with CO2, so that's likely playing a role. In terms of the findings, Dr. Dahman mentioned many of them. Certainly this presented itself initially as hyperoptic shift, so a change in vision. This may be due to pressure on the back of the globe or swelling of the choroid, such that you're no longer focusing at the retina anymore. So you can still see reasonably at a distance, but not up close. Papilledema, so that's a very significant finding, and as you know in clinical medicine, that's a finding of elevated intracranial pressure. Or the corollary is you have low intraocular pressure, but none of the crew have been found to have low intraocular pressure in flight. So that's a sign of elevated intracranial pressure. The choroidal folds, and this is the vascular network underneath the retina. There have been folds in this suggestive of either a decreased area from globe flattening or probably engorgement from venous volume. Globe flattening has been observed both in ultrasound on board and post-flight with MRI, and I'm sure Dr. Kramer will talk more about that. And increased optic nerve sheath diameter. So the optic nerve is surrounded by cerebrospinal fluid, which communicates with the subarachnoid space, and there's a sheath around that. So if the idea is if that diameter increases, that's a sign of elevated intracranial pressure. And so that's been found to be significantly elevated. In addition, there have been a number of crew members with cotton wool spots, so the appearance of small infarctions in the retina. So I just want to touch on incidence and then talk about some of the evidence, and I'll end there because Dr. Hart will talk about the CPGs. But looking at 36 crew members who've flown, there are 15 what we call cases. So that's an incidence of nearly 42% spread across 4 CPGs. Clinical practice guidelines increasing in severity from 1 to 4. We, in terms of non-confirmed cases, there's only 2 non-confirmed cases. There are 19 individuals, there just isn't enough data, so there would be they are unclassified at this point in time. There's 2 in class 1, the lowest severity, 8 in class 2. That represents 30% of the affected. And in the 2 more severe classes, 3 and 4, we have 1 in class 3 and 4 in class 4. And so in class 4, you've got elevated intracranial pressure and papilledema. Again, Steve will talk a little bit more about that. Just to finish up on the data mining, we have initiated a data mining effort that we've been undertaking over the past 5 months, and that's revealed some significant results. Just to preface those comments, that there are really 3 systems involved in this problem: the cardiovascular system, the brain, and the eye. When we look at the cardiovascular system, particularly the venous side, compliance of the venous system probably plays a very large role. And when we look at factors that affect vascular health or endothelial function, we found a significance across CPG 1 to 4. So if you're in a more severe class, you're more likely to have higher blood lipids, LDL, and that's significant. We looked at this at annual exams over a 3 to 4 year period. Your fasting glucose is likely to be higher if you're in a more severe case. Your hemoglobin A1C will also be higher. Your systolic blood pressure will be significantly higher. Homocysteine, which is a marker of vascular health, will be higher. And also your maximal oxygen consumption will be lower. And oxygen consumption is correlated with vascular elasticity. So these are all signs that individuals with stiffer pipes, if you will, are probably transmitting those pressures and causing more resistance to venous outflow. And in the brain, we've seen optic nerve sheath distension, globe flattening, papilledema, and ICP, I forgot to mention that earlier, in 4 crew members between 21 and 28.5 millimeters of mercury, and that's on the ground post-flight. I would suspect you're probably seeing pressures perhaps in the 30s and 40s in flight, and we just don't have a way to measure that currently. And we've mentioned a number of the eye findings, but I think I'll stop there. And
Okay.
Thanks, Mike.
Thank you, Kristen. That was a very good overview. And Dr. Kramer will review some of the anatomical findings. And Dr. Kramer has the distinction of being the only exception to be able to show graphics here today. So we'll be showing, we can get the first slide up right now. Dr. Kramer?
Well, we could hold off on the slide till a little later.
Okay.
Anyway, Mike, it's a great honor to be here today. I had the opportunity to evaluate the brain and orbits of astronauts exposed to microgravity using magnetic resonance imaging. What began as a single study rapidly grew into multiple exams over the course of 3 years. Our experience with 27 astronauts will be published in next month's issue of the journal Radiology. As a radiologist, I'm accustomed to speaking in the backdrop of slides, so I'll do my best to describe our results in the absence of images, although I've been granted 2 slides, which I will present at the end. Let's start with a description of the abnormalities of the eye. The eye consists of a globe which has a round contour, a lens, light-transmitting aqueous and vitreous material, and a light-sensitive retina. The posterior aspect of the globe is pierced by the optic nerve, in which the retinal fibers coalesce. This point of coalescence is referred to as the papilla. The inner margin of the papilla has a normal concavity, or is referred to as a physiologic cup. The papilla transitions posteriorly into the intraorbital optic nerve, which is surrounded by cerebral spinal fluid, which is also in continuity with the cerebral spinal fluid within the intracranial space. This is a very important point. The diameter of the fluid surrounding the optic nerve has been shown to expand with increasing cerebral spinal fluid pressure. We found that the diameter was abnormal in 52% of the astronauts studied. We also found that the optic papilla lost its physiologic cup and was protruding into the vitreous in 15% of long-duration astronauts. In our study, we defined long duration as greater than 30 days of cumulative exposure to microgravity. Optic disc protrusion, when associated with edema of the optic nerve due to elevated intracranial pressure, can result in severe visual problems, including blindness. This abnormality was not found in short-duration astronauts with exposure under 30 days. The posterior globe, which is normally round, was found to be flattened in 22% of long duration and 4% of short duration astronauts. We documented new flattening in 1 astronaut after flight compared to a baseline study, which I will demonstrate later. We also looked at the contour of the optic nerve sheath, which contains the optic nerve and surrounding fluid, and found that there was a kink in 11% of the long duration astronauts and 4% of the short duration astronauts. The kink was always associated with increased cerebral spinal fluid diameter, indicating elevated pressure. The distribution of abnormalities suggested that there was an increasing incidence and severity of abnormalities in the long duration group. The constellation of these orbital findings can all be associated with elevated intracranial pressures. The intracranial findings were limited to the pituitary gland. The normal pituitary gland has a flat or convex dome with a centrally located pituitary stalk. In 11% of the long-duration astronauts, the pituitary dome shows significant concavity and posterior displacement of the pituitary stalk. These are imaging abnormalities also associated with elevated intracranial pressure. Okay, I now think we can go to the first slide.
Great.
Here's an example of a normal and abnormal posterior globe contour. On the left, we see a sagittal projection of the globe in an astronaut at baseline. We can appreciate the lens surrounded by the bright signal intensity of the aqueous and vitreous material. The red arrows show a normal posterior convexity of the globe. The image on the right is the same astronaut now post-flight in the same sagittal projection. The dashed red arrows now show flattening of the posterior contour of the globe. Next slide, please. Here's an example of a normal and abnormal pituitary gland in two different astronauts. On the left is a normal pituitary gland obtained in the mid-sagittal projection. The dome of the pituitary gland, as indicated by the red arrow, has now a mild upward convexity. The pituitary stalk is midline, as indicated by the black arrow. On the right is an example of an abnormal pituitary gland in the mid-sagittal plane. The red arrow now indicates severe concavity of the dome. The black arrow indicates posterior displacement of the pituitary stalk well off midline. These changes are believed to be secondary to downward herniation of the cerebral spinal fluid due to elevated pressures. In conclusion, the combination of orbital and intracranial abnormalities support the concept of elevated intracranial pressure in a subset of astronauts. In 3 astronauts, borderline or mildly raised intracranial pressure was confirmed by direct pressure measurement via lumbar puncture.
Okay, thank you, Dr. Kramer. Dr. Hart will go over some of the clinical practice guidelines and again, how we're applying this knowledge.
Thanks, Mike. In addition, I'm going to cover a little bit about pre-flight and post-flight testing and a little bit of in-flight testing. But so basically, for the first 50 years of manned spaceflight in the U.S. program experience, we've been pretty limited in what we've been doing. I mean, certainly cutting edge for the times, but until about 3 years ago, all we were really doing for our on-ground studies were typical traditional visual examinations in the ophthalmologist's office. We've been taking retinal photos for a long time, and we were doing intraocular pressure. And in flight over the years, we've done intraocular pressure as well, and some acuity-based DSOs and DTOs and things, but nothing consistently. And until 3 years ago, we did not have a Snellen chart with typical letters and numbers on board the station and a consistent way to even evaluate acuity. So really 3 years ago, as we became more aware of this problem that's been discussed, that really ramped up our efforts to characterize the problem more clearly on board as well as on the ground. So in the last 3 years, we've developed ultrasound protocols that we're doing, as well as MRI that Dr. Kramer just described as well. Ultrasound for visualizing the optic nerve sheath diameter, and MRI for the eye anatomy, as well as the rest of the brain with higher resolution. And then ocular coherence tomography to get more detail on the fundus and retinal nerve fiber layers. And on board, as I mentioned, we now have better ways to evaluate acuity with Snellen charts, and in the future we'll have laptop-based acuity tests. We're doing ultrasound, of course, with Dr. Sargassian's help. And we also have on board now, we did have just a regular old-fashioned ophthalmoscope for years that we were able to use, but no way to capture that imagery and send it to the ground. So we were based on crew members' descriptions, some of them medically trained, others not, to tell us what they saw. But now we have ways to capture both still imagery and video, so we can see venous pulsations and everything else. And we're going to be increasing resolution with time over that. But so the point is, we're catching up. It's as always with getting spaceflight hardware and procedures up, it's challenging and slower than we'd like it to be, but we're optimistic about the future, current situation as well as future developments with more laptop-based testing, visual fields, and further down the road, by next year we should have OCT on board and visual field testing on board, and we look to more non-invasive intracranial pressure measurement techniques over the next few years as well. I was asked briefly to speak about the clinical practice guidelines. So these are just guidelines for management decisions, for diagnosis, management, and treatment. So as Dr. Otto mentioned, and I'll limit this just to the 34 U.S. patients or subjects that we've had to study. So we break it down into 5 classes, 0 to 4. Within the first class, 0, as you'd expect, these are subjects which had none of the problems that we've talked about here. And I'll qualify this by saying, we have 21 people in this group, but 19 of those are really incomplete and not very classifiable in that we don't have all the data that we have on our later subjects. So, they could have had optic nerve sheath diameter changes, but we've not measured them. So, but again, so 21 people in that class, or 2, depending on how you cut it. And so these are people that had no or less than 5 diopter change in refraction, and they had no evidence of papilledema, cotton wool spots, choroidal folds, globe flattening as demonstrated here, or visual scotoma. So again, these are the people that are clean. So if you have any refractive change greater than 0.5 diopters, that moves you up into class 1. And all we do for those patients is we repeat OCT studies on a schedule every 6 weeks until we see that everything is returned to baseline in terms of their vision changes. So we have 2 people in that group, as Dr. Otto mentioned. If we see on top of that situation a refractive change, if we see choroidal folds or optic nerve sheath diameter changes, then that kicks you up into the next class, class 2. And we have 8 subjects in that category. And also globe flattening is in that group, and or scotoma. And but again, these are not people that have developed any, optic nerve swelling or papilledema. And so 8 subjects in that group. And all we do for those is we repeat OCT. We increase our vigilance in terms of the other studies as well on the schedule, and we follow them out until return to normal. Repeat MRI in 6 months, and we have a schedule built up for all these. But and as has already been alluded, we have some subjects in which there was not a return to baseline. So class 3 is characterized by actually having optic nerve sheath distension, globe flattening, choroidal folds, and the scotoma. Again, you have to have vision changes greater than 0.5 to be in this group, and we have only 1 subject in that category right now. We are a subject that has grade 0 to 2 papilledema is also in this group. And again, all we do for these is similar to the other groups. We just increase our vigilance, and we have a schedule for testing them out over the next 6 months or until symptoms clear. So the most serious, severe category is class 4. We have 4 subjects in that group. And these are folks that could herald on board with their symptoms developing headache, pulsatile tinnitus, transient visual obscurations, transient blurring of vision while they're on board, and then they would typically have all the features that we mentioned before, so distension, globe flattening, cotton wool spots, refractive changes, etc. And they would also be folks that we would have brought down and done post-flight testing of intracranial pressure with a standard LP, and that would be higher than 25 millimeters of CSF to enter that group. So, and these are the folks that we would talk about treating. We have had only 2 people that we've thought about treating on board that I'm aware of, and that thus far have not really done anything. We've talked about using Diamox, talked about mitigating with control of the CO2 levels and sodium in the diet, but it'll be challenging. But we are, increasing our screening of folks on board. As we have all these new modalities coming online, we'll probably be seeing more subjects in better stratified according to these when we get in-flight data to support this. So
We're at time here.
that's all I have. Thanks.
Okay, and just to clarify, have we seen headaches, tinnitus, all this issue?
Well, I'm sure the entire group's aware of headaches associated with spaceflight early on. I've not heard of tinnitus in any subject, pulsatile tinnitus, but certainly headaches, and it's hard to sort that out from all the other reasons that we see headaches on board, typically early on. But.
Okay. Dr. Kozlowska, you have some comments for us?
Ну, у меня комментарий достаточно короткий.
My comments will be brief. First,
те данные, которые сейчас уже накоплены,
I think that the data we've managed to accumulate so far
чтобы
require
были просмотрены
that
вот эти изменения, которые
those
произошли
changes
после полета. Я просто не очень могу
be
сейчас
correlated,
фиксировать в том, что докладе,
because for me
что
it's
виделось
pretty hard
после полета.
to differentiate between what you saw during the flight and post-flight. But I think my understanding that the bulk of those studies took place after the flight, including changes in the intracranial pressure. And we should realize that the changes in intracranial pressure could happen not necessarily because of the changes in the eye, but rather because of some other reasons. And primarily because of the fact that the person hasn't been exposed to gravity for an extended period of time.
Признаков изменений
So we just blindly, we just cannot blame the changes in the eye if we see any changes in
мы даже знаем,
if we see the changes in the intracranial pressure. And headaches that we see very often actually could be compensated
которые докладывают.
based on our experience
Простой процедурой
just by
надевания ноги, которые
just by wearing special garments, special socks, which regulate the flow of blood in the body. And those are different things. I don't want for anyone to actually mix those two things together.
прямой переход переполнения
So excessive blood flow and changes of the intracranial pressure because of some changes in the eye, those are two different things. So we need to keep looking, and we need to collect more and more data to verify and substantiate all those findings. Secondly, I think you mentioned, several previous speakers mentioned that there are all reasons
прямых оснований экспериментальных у нас нет.
to believe, although we don't have direct reasons to believe. We have only reasons to assume that excessive resistive exercises, or rather modes which are being chosen of those exercises, and variability of different modes of resistive exercises could be potentially a source, because we are not seeing that many changes in our cosmonauts. And those are the ones that don't overwhelmingly prefer ARED equipment to resistive exercise, but we do have a group of enthusiasts of ARED. But at the same time, the values of the loads are reasonable, and they are a lot more thought through as compared to the U.S. complement of the crew. Otherwise, I cannot really understand how different aspects, food, nutrition, sleep shifting, we don't see any changes. Well, changes in physical exercises, yes. And I'm responsible for putting together plans for the physical exercises on board, and I spend a lot of time with sports physiologists, and I know that we have seen changes in the eyes before, but we call it a professional hazard, something that we have been seeing in athletes for a long time. And lastly, I had gotten very interested to hearing more about those cotton spots or something like that, because this is something that is not observed under normal circumstances, because we shouldn't be forgetting about one more phenomena to be observed on orbit, and it's the impact of heavy particles. All cosmonauts and astronauts know that. They experience flashes, and those flashes are the influence of those hard particles, and first of all, they are heavy as they are, and second of all, they penetrate through the vehicle at a very high speed. And we do have a special program, actually, that is
опытными зрительщиками, которые занимаются
involved in
исследованием
finding out more and studying more purely
residual от этих
morphological
на уровне
residual
только на уровне
results of
систем головного мозга.
whatever impact those
И короткие
flashes,
зрительные
or rather those heavy particles and subsequently flashes,
в частности, гипофиз они смотрели.
affect the eye and the body of the human being in general. There's great many different factors. Now, one thing that makes me nervous that variable signatures that we are seeing in different crew members. This is something that is actually alerting us, because we're seeing commonalities, but every time we're seeing different disbalance, asymmetry.
Американские группы.
But the asymmetry toward the U.S. complement of the crew, this is something that makes me shiver, because I'm responsible of the well-being of the crew regardless of whether or not this is U.S. or Russian or anybody else. And it does not require any experiments. It does require a certain compliance, certain discipline. We just need, we could use variable loads, different regimens, different protocols, but we just need to differentiate between what we do for any particular group of people in order to see the difference. And I'd like to draw your attention to the situation which we had with Vladimir Titov during his one-year-long flight, and we were doing very different efforts in order to assess the situation. This is something that we need to capitalize.
I hadn't thought of before, and to each of those, there's probably hours of discussion. I want to give Dr. Bogomolov, Valery Vasilyevich, a chance to make a few minutes worth of comments.
First off, I would like to mention that the blood circulation associated with the possibility of changes in the intracranial pressure have been addressed during the very beginning of space era. I used to think that this issue will always be very important. I'm of the same opinion right now. And we have been doing a lot of testing on the animals in order to see what kind of changes occur in an animal depending on the various external effects. And we've done a lot of experiments with my colleagues of Nigovsky group, and worked out several methods to correct that would allow us to provide certain therapeutic effect on those who experience those things, like swelling of the brain, for instance, and things like that. Later on, the practice of the space flight showed that predominantly we have not seen too many changes as far as quality of vision. Furthermore, during the long-duration flight, we were seeing actually increase in the quality of vision rather than decrease. And
это подтверждается и в наших
which we have found enough proof during our long-duration flight in the past, and we are actually getting the information that proves this concept even currently. But what changes in the function of the eye post-flight? Usually, almost every single cosmonaut experienced some degree of swelling. Presence of tiny particles of blood, and it depends a lot on the actual impact. It depends on how well and how soft the actual landing was.
Изменения достаточно кратковременные.
Those changes are short-term and normally disappear by the 5th day post-flight.
Не было российской
We have not seen neither on Salyut nor on Mir station, to say nothing of the ISS.
указаний на
We haven't seen anything even remotely related to
зрительного нерва,
optical nerve
косвенных признаков.
or even indirect reasons that could lead us to believe that there were some changes in the intracranial pressure. Although we were looking and we were looking as hard as we could.
Инесса Венедиктовна на обезьянах исследована, вы еще
And
На обезьянах в полете мы применяли прямые
Inessa Venedictovna was doing a lot of experiments on monkeys during the flight, and we have not found any changes whatsoever. And we were getting these data of the number of sensors.
антиортостаза минус 90 градусов. На собаках мы тоже, так сказать, длительного повышения внутричерепного давления не видели. Мы видели анемию, так далее, но не внутричерепное давление. Все же организм – это сложная саморегулирующая система.
To realize the human body is a self-controlling
Система
system.
компенсаторных
It's a
механизмов
compensation system
достаточно,
that the human body is equipped with. Is quite a powerful
чтобы мы не
system.
делали,
No matter what we do,
организм сохраняет
our body will restore itself and maintain its performance and capabilities.
с мозга в первую очередь.
And the brain, first and foremost,
потому что мозг,
especially when it comes to the brain, because the brain is in a special set of
механизм,
conditions, and it's a unique self-controlling mechanism. Inessa,
так сказать, выступить, я буду очень
if you have a separate statement later, I'll be real joyful, but you don't have to keep whispering in my ear.
а это меня сбивает.
Yeah, because I have to listen, and that that throws me a little.
Итак, у российских членов экипажа
Let's continue. Nothing like that's been registered on the Russian crew members. Having said that, over the last 3 years that we've been discussing this in great detail,
и
and as we have been
совершенно очевидные.
tackling this issue, the first question comes up is obvious. Why now? Why these changes are occurring now? How come we haven't been seeing them over the last 50 years of space era at all?
Может быть, несколько причин.
There could be several underlying reasons for that. It could be technological based. Maybe it's the research capabilities that have been increased so much that we are actually able to tap into something that we hadn't been able to see before due to the kind of equipment we didn't have before. But maybe it's due to the fact that there's a difference between ISS and Mir. What are those differences, possibly? First off, we're talking about habitation and environment features, atmosphere-wise, food-wise, thermal control-wise, performance and schedule-wise, then you don't really see any differences at all. Where you do start seeing those deltas is when you start looking into the new countermeasures that had not been available before, i.e. the resistive exercise devices, ARED, that we've got on station now, even though there was a resistive type of regimen implemented on Mir station. Based on special loading exercises, but not to the degree that we've got on station now. What else makes station different from Mir? Volume, size.
размеры
Goes without saying that
станций
the sizes, the station's dimensions,
большим количеством техники
and
могут
the sheer amount of equipment
иные условия
that is got could provide for a different electromagnetic environment and its impacts on humans.
просто рассуждаю. Это я
I'm basically
утверждаю.
I'm not making any firm statements. I'm just talking out loud,
Используемые
trying to
техники,
also mention the level of optical gadgetry that we now have that's available, the computers, the comm assets, and
Поэтому
just to name a few.
в этих направлениях
And so
надо искать
this is a vector for us to follow, and this is what the path we should pursue to kind of seek out the causes of these changes. There's been some real convincing data, reports provided, both at the multilateral medical community level and both on the certification, health certification panel,
по политике.
and both the medical policy board and everyone as one had to admit that this is a risk factor of a long-duration spaceflight. And at this point in time,
Нас это обязательно.
what we put all of the crews through is we sit them down and we talk to them about this factor being there. That's an important one to take into account. It's a important one to be somewhat cautious about. And should any symptoms arrive, any visual changes, any neurological changes arrive, to make sure to put us in the loop
Если
as soon as possible.
американского сегмента исследования
And if
состояния
the research of the visual capabilities that's been done for the USOS crew, and if
для российских
it's become a must for all the USOS crew members, this is a extracurricular one for the Russians. It's based on the actual data. We did it on 2 Russian crew members in flight. We did not see any changes whatsoever. Moving on to something else I wanted to mention here and now.
контроля длительных полетов
As regards long-term medical monitoring, neurological monitoring capabilities is kind of a weakest link in the chain.
объективных методов
Pretty much we don't have any objective monitoring and research techniques when it comes to the neurological
что до сих пор
field.
это не
Why is that?
тестировалось.
It's because it has not manifested itself to date. And so it kind of fell off the radar
В то
somewhat.
время, как я думаю, что
While at the same time,
развитие
the
методов оценки
methodology and assessment methodology development in spaceflight,
недальнего космоса
given that we're talking about deep space exploration, becomes ever more critical. It's basically kind of a flaw to the space medicine
Ну и
globally
для того, чтобы
at this point in time.
всесторонне эту
But in order for us to take a multilateral, multifaceted approach towards this issue, we do, I have to tell you, we do have an intention to initiate visual function research
состояние неврологического
and neurological status research using the entire complex of what's being used with respect to the USOS crew members as well as to the Russian crew members to make it an indelible part of medical monitoring and medical supervision in order to start researching this.
до настоящего времени
Up to this point in time,
у нас
we cannot say that
проблемы
that we've had this
не было.
as an issue at all. It's been a non-issue on the Russian side.
Если скажу, что
But
совсем не было.
I'll be lying if I say that it hasn't happened at all. Because 2 crew members, there have been 2 cosmonauts that did use the resistive exercise devices and did their whole physical exercise regimen, and otherwise post-flight they did manifest some changes, some inconsistencies as far as the optic nerve, and in one case there were visual losses that were identified. A scotoma was identified, which was a critical finding for us, that these changes, even though they were identified over a course of 1 month, disappeared.
Поэтому я считаю, что и у нас есть основания для того,
And with that in mind,
чтобы ввести эту
I
программу и
can say that we have reason enough to start talking about making this a uniform program, a protocol that will be applying to the Russian crew members too. Both Michael and I already discussed this at length, and Dr. Ashat Sarkisyan and I already discussed this at length in our group, and so I think that we will be able to make that happen in the nearest future. Thank you very much for your time.
Thank you, Valery Vasilievich. It may seem like a long time, a couple of years, to get us working in a fairly coordinated fashion, but for those of us that have been around the U.S.-Russian program, that's pretty quick. And we will, I think, get to this answer much quicker in a coordinated program, especially drawing on the Russians' long-time expertise in zero-gravity physiology. And Dr. Kontintsev will be our last commenter. And I think in the interest of time, and I know that we have a lunchtime speaker, we will not open the floor to questions afterwards. But if you want to grab any of us up here to ask questions, I'm sure that they will be more than willing to. So Dr. Kontintsev, if you could conclude us.
Thank you very much. I won't take too much of your time, and I don't have much to add, whatever our distinguished experts already told us. I just want to reconfirm that we haven't been seeing any changes, and this is applicable particularly for EVA sessions. And I would like to admit that I agree that we have seen improvements in the acuity of the vision as a result of long-duration flights. Secondly, I'd like to take you back to our MIR program. During the times of the MIR program, we were doing a lot of volume of scientific research associated with the peculiarities of circulation, blood circulation during the long-duration flight, and we were paying a lot of attention to this particular aspect of the crew well-being, and we had a lot of findings that proved to us that some objects, some cosmonauts, show certain manifests associated indirectly with the possibility of excessive intracranial pressure after long-duration flights on a MIR station. And the procedures and those findings, they have been published in a 2-volume scientific and research paper. The authors of these volumes are Professor Mesnikov and Professor Stepanova. I do have a copy of this particular chapter that has to do with Dr. Otto's effort in this regard, and I would be more than happy to pass this information. It's in Russian, I have to apologize, but it's fairly easy to translate, and maybe Dr. Otto wouldn't even need any translation because it does have some actual pictures which are self-explanatory, and needless to say that this is a pathology that we owe to ourselves to take a hard look at and to do everything we can as medical people to mitigate the after effect of those things. Thank you very much for your kind attention.
Thank you, Dr. Kontintsev. One quick comment from Dr. Otto. Really quick comment.
It'll be quick. I just think it's interesting that you mentioned that some individuals' vision has improved, and when you think about the mechanism that we think is behind this, if you're myopic, so your globe is more elongated when you fly, and your focal point is in front of the retina, so your vision, that's just, you're getting older, you're myopic. Well, what we see is happening in the hyperoptic shift is the retina is being pushed forward. So if you're myopic and your retina is pushed forward from pressure, that will improve your vision. And just one other last comment, I think Inessa's comment is valid, and it's fair criticism that the in-flight diagnostics is limited. However, and this is credit to the Wiley team led by Dr. Sarkisyan and the in-flight ultrasound that they're doing, is that ONSD has been found to increase in-flight, so from pre-flight to in-flight significantly, from 0.59 centimeters to 0.69 centimeters in the affected crew. and increased ONSD is associated with elevated ICP. We've also seen the eyeball, if you will, get squished. There's smaller AP diameter, another suggestion of elevated intracranial pressure, and that sign has 100% specificity in idiopathic intracranial hypertension. And another reason the incidence may be a little lower in the Russian population is their use of bracelet and chibis, which draws down that venous congestion. Thanks, Mike.
Okay, thanks very much. There's many facets to this. The article that broke the story was written, lead author was Thomas Mader. It came out in the Journal of Ophthalmology in October, November or so of last year. It's a very good overview of it, and there's a lot of work to do. It's very interesting for us. Thank you very much for your attention. Thank you to the panel for helping us today. And I'm sure that any of these guys are 10 layers deep in detail if you want further questions answered.
По каким признакам?